Good afternoon, everyone. My name is Megan Williams, and I'm the Director of Support Services at Alzheimer Group. Thank you so much for joining us at today's lecture called Exploring Mild Cognitive Impairments, MCI, and How to Keep Your Healthy Brain. If you're joining us for the first time, AGI supports people living with dementia and their families. Our services include online activities, counseling, education, and support groups for caregivers. We will be slowly resuming in-person activities in the fall, so stay tuned. Today's lecture is made possible by the generous support of the Lindsay Memorial Foundation. AGI is a charitable organization, and we rely on support of donations. This is a free lecture, but you are welcome to donate at any time by calling us or visiting our website. Today's lecture, everyone will be on mute, and you can use the Q&A or the chat function to ask any questions. Questions will be answered at the end of the presentation. Without further ado, I'd like to introduce you to today's guest speaker. Dr. Elise Levinoff joined the Jewish General Hospital Division of Geriatric Medicine in 2014. And she also has a role as an assistant professor in the Department of Medicine at McGill University. After receiving a master's in neuroscience at McGill, Dr. Levinoff earned her medical degree at the University of Ottawa and then returned to McGill for postgraduate training in internal medicine and a fellowship in geriatric medicine. She has also completed training in cognitive disorders in the elderly. Dr. Levinoff is active at the Jewish General Hospital Memory Clinic and pursues clinical research in mild cognitive impairment and its association with the development of delirium during hospitalization. As I said, Dr. Levinoff will be answering questions at the end of today's lecture. So without further ado, Dr. Levinoff, I'm going to give you the floor.
Thanks, Megan. So thank you very much, everybody, for coming this afternoon. I think it's really important to advocate and educate the community about cognitive impairment, and specifically today, mild cognitive impairment. So I'm going to talk for maybe about 30 or so minutes, and then I'm going to actually show a video that was done by my mentor and colleague, Dr. Churko. Some of you may know him. And if you have questions, what I would say is either write them in the chat box or write them down on a piece of paper and you can ask me after. Okay, so let's see here. Okay, so I just want to say I have no conflicts of interest to disclose. And as Megan mentioned, I'm a staff geriatrician at the Memory Clinic. So it's the Clinic for Cognition and the Ambulatory Geriatrics Clinic at the Jewish General Hospital. I also act as a consulting physician in the emergency department at the hospital and throughout all the inpatient units, as well as at the CHSLD Jewish Elder Care. And I always like to say that I'm an advocate for older people in the community and in the hospital. All right, so as an outline, what I'm going to talk to you today about is what is mild cognitive impairment? What is my risk of developing mild cognitive impairment? How would my doctor diagnose mild cognitive impairment if I were to come into the clinic? And what are the treatment options? I'm also going to talk a little bit about how it differs from both major neurocognitive disorder and also normal aging. And a lot of questions often come up: do people with mild cognitive impairment eventually develop major neurocognitive disorder? And what can I do to prevent it from getting worse? So I want to bring up the fact that aging is not a new phenomenon, but that cognitive impairment is an age-associated phenomenon. So diseases of cognitive impairment do have a higher incidence as you age. And we know that. And we also know actually that cognitive concerns, a lot of older people tend to present to their doctors or their clinicians with memory impairment. That doesn't preclude younger aged people from developing memory impairments. However, we know that as you age, the incidence rises, okay? So you can see that the incidence of dementia, which is again, not mild cognitive impairments, and I'll speak about that in a minute, is about 43 per 1,000 persons in the age 65 to 79 age group, but it increases actually quite considerably in the age group of over 85. And we know today in Canada that there's at least 500,000 people living with dementia, and that's a formal, that's people who have had a formal diagnosis of dementia. And this number is expected to rise, as we know, because the population is actually changing over time. We know that around 25,000 Canadians will be diagnosed with dementia each year. That's just a little bit of a snapshot of sort of cognitive impairment in Canada. It's a little bit harder to predict what the incidence is of mild cognitive impairment because there's such a wide range, and I'll talk about that in a second. So what is mild cognitive impairment? It's really what I would call sort of a continuum in the stage of cognitive decline. But it's not necessarily a continuum in the sense that everybody with mild cognitive impairments will develop, say, major neurocognitive disorder or Alzheimer's disease or dementia. But it's sort of on a spectrum. And it really involves, in order to make a proper diagnosis, what you really need to do is you need to see your doctor, but you need to have evidence, or you need people who have mild cognitive impairment really need to say, my memory's not as good as it used to be. And their doctor will do a test, but the memory impairment is not significant enough to affect everyday life, so day-to-day functioning. So if you think your cognition has changed over time, you may be right. And it's important to note that family doctors don't routinely screen their patients for cognitive changes because it's actually not indicated. And people with cognitive concerns or concerns about their memory or their cognition often present to their physicians with subjective concerns. They'll say, it's not as good as it used to be, or often what doctors will hear is, I can't produce the words. It's like they're on the tip of my tongue. And the doctors will often, and they'll ask their doctors if your memory is supposed to be worse as you age. And this often results in a referral to a cognitive assessment clinic or a specialized clinic like the memory clinic. It's important to note that people with mild cognitive impairment, this continuum of cognitive impairment, can have deficits or impairments in certain cognitive domains. So it's not just a memory problem, it can be a language problem. As I mentioned, oftentimes people will say, oh, I can't say the word. I used to know the word a lot better. Or a lot of people who are bilingual or even trilingual often say the word comes to me in French, but I have a difficult time remembering it in English. And usually it's the native language that is a little bit easier to retrieve the word. Oftentimes patients might complain of visual spatial functioning. So their ability to sort of put things in time and space at the same time might be a little bit impaired. And executive functioning is actually very common in the sense that they find that sometimes it's harder to do complex calculations or complex tasks that they once used to do in an easier way. Now, we know that memory is the most common form of cognitive impairment, but again, other cognitive concerns can arise. So if you do go to see a specific doctor about your memory problems or your cognitive problems, you have to be really specific with your doctor about what you think has changed. It's important to remember that people with a diagnosis of mild cognitive impairment do not have Alzheimer's disease. People who receive a diagnosis of MCI do not have dementia. So these are two very different aspects. And I'll talk about sort of how they relate to one another in a few minutes. People who have short-term memory deficits, so they'll say, I feel like I'm repeating myself or I'm misplacing things, or sometimes I'll be driving and I'll forget all of a sudden where I am, but it will come back to me. They often have the term called amnestic MCI. And amnestic comes from actually the word amnesia, which is either, I'm not sure if it's Latin or Greek, but it comes from amnesia, meaning that they forget things in an easier manner. But if people have other cognitive deficits, they have what we would call non-amnestic MCI. So as I mentioned in the previous slide, you can have language impairments, but not memory impairments. And that might mean that you have non-amnestic MCI. Now, I really want to emphasize that not all people who are diagnosed with mild cognitive impairment progress to develop Alzheimer's disease, but some do. And we know that it's around 10 to 15% of people per year. So what I often like to tell people, to put it into context, is if you take 100 people in a room who all have mild cognitive impairment and you follow them over time, each year about 8 to 10, at the most 15 people actually leave that room and they go into another room. Now, in fact, some of them actually might even get better, and we'll talk about some of the things that can be done to make it better. Some of them actually stay the same and some of them progress. What are the risk factors for MCI? Well, for sure, as I mentioned before, age. So the prevalence of MCI in people over age 70 ranges anywhere between 9 to 35.5%. And you see, I'm always a little bit hesitant to bring that up because that's actually quite a wide range. And the reason that it's quite a wide range like that is usually because at some points it can go undiagnosed. Sometimes people get better, sometimes people get a little worse. Sometimes when you tell your doctor, or you give your doctor a history and you say, yes, I'm fully functional, I can compensate despite my memory deficits. In fact, there might be some subtle functional deficits, and that's a different diagnosis. We also know that men appear to be at higher risk. We know that education level is actually a protective risk factor. And I can actually get into that a little bit afterwards if there are specific questions about that. We know that people who have diabetes and hypertension also have a higher risk profile as well. And I often say to my patients, well, if you have a heart attack on your heart and it affects the blood vessels in your heart, you're also going to be at risk for having a heart attack in your brain, because the blood vessels in your brain are not spared in the same way, are not spared just like the blood vessels in your heart. We know that a certain genotype called the ApoE epsilon genotype, so that's a specific gene, does put you at higher risk, but it's not always the case that it's 100%. If you have this gene, you will progress or you will develop mild cognitive impairment. There's been a bit of evidence that vitamin D deficiency is also a risk factor for mild cognitive impairment. Vitamin D is, and I'll get into that a little bit afterwards, vitamin D is sort of one of those vitamins that doesn't really cause a lot of harm if it's not over ingested. And it's also useful for people who have osteoporosis, which is another common disease associated with aging. So we often tend to put a lot of our patients on vitamin D supplements in any event. And we know that sleep apnea can put you at high risk, because if your brain is not getting the oxygen that it needs when you sleep, or if you're not getting the appropriate sleep, or your sleep hygiene is impaired, it's definitely going to have a direct impact on your cognition. And we also know that people who have had prior critical illnesses are at risk for developing cognitive impairment, specifically mild cognitive impairment. So how does my doctor know that I have mild cognitive impairment? And I sort of wanted to walk you through a little bit of this, because I think it's really important to understand. Doctors can use different sort of methods to make a diagnosis, okay? But the most common diagnostic mechanism is what's called a clinical exam, which means that you ask the patient some questions and you perform a physical exam. And sometimes there are other tests that can be done, such as head scans, and I'll get into those as well, can be used as adjunct information. But we don't diagnose memory impairments just on the basis of a head scan alone. So we need to talk to our patients and get an understanding of what's going on. So when you see your doctor, if you think you have suspected cognitive impairment, your doctor often asks you, what are your other medical conditions? Do you have a family history of memory problems or cognitive impairments? When did the cognitive deficits or the cognitive findings start to appear? Was there anything that may have precipitated it or brought it on? And how has it progressed? And the key here is that, the key point to note here is that, does it have a direct impact on day-to-day functioning? And the reason that that's really important is because that's the most common thing that differentiates a person with mild cognitive impairment from a person who has what we would say dementia or Alzheimer's disease, which is a form of dementia, okay? So again, if you have MCI, that doesn't mean that you have dementia. And it's really important to ascertain if there's been a change in day-to-day functioning. So for example, if you're an accountant and you were previously doing your own taxes a few years ago, but now you find it harder because that might impact your executive functioning or your complex planning abilities, that might signify that you have an impaired day-to-day functioning. Okay, so each person has sort of a different baseline, and each person might have a change from that baseline. So it's really important that when you see a doctor who might assess your cognition, it's really important to come with someone who knows you well and knows how you are coping, both psychologically, functionally, and cognitively, despite your concerns. And this person often is the one who will be able to tell your doctor if there are changes on a day-to-day basis that weren't present maybe 6 or 12 months ago, okay? The diagnosis, again, is based on history and physical exam. Your doctor will also do a full physical examination, and that's to assess to see if maybe there's a heart murmur that you might have that might impact the amount of blood that gets to your brain at an appropriate manner. Or maybe the doctor will examine you to see if there's any neurological changes that have occurred, because sometimes people who might have had a small stroke that wasn't apparent, a small stroke that wasn't apparent in the past, that also can have a direct impact on cognition as well. As part of your physical exam, or as part of a physical examination for assessing for cognition, the doctor does, I wouldn't say it's a memory test per se, but I would say it's a cognitive test. And the purpose of the cognitive test is to determine if there are any cognitive deficits. So that means don't expect to get a perfect score on the test. A perfect score on a test means that it's not a good test. All tests that are used to assess memory or cognition are designed for people not to get 100%, and they're also designed for people not to get 0. So a good test is one where you can see some problems, but you can also see some benefits, okay? And again, the test it's very much like a head scan. It's not a diagnostic criteria. It doesn't make or break a diagnosis, okay? It helps. It's an ancillary test. It's unfortunate because with people who have memory problems, we don't have a blood test like we do for, say, diabetes, where we can do a blood test and your doctor says, okay, your sugar is over 10, let's treat your diabetes and we'll see if your sugar can get better. Unfortunately, we have to rely a lot on our history and our physical exam and some of our ancillary tests. Okay. The test is also useful for following people over time. And the most common test that we use actually in the memory clinic is the Montreal Cognitive Assessment Battery. Some people who are listening may have heard about the MoCA. The MoCA is a really, really good, well-rounded test because it can assess not only memory, but also attention, language, executive functions, so complex tasks, as well as calculations and abstractions. So again, don't ever expect to get 100% on a memory test because it's not a good test if you do. And also it's important to keep in mind that when you do a MoCA, it can be affected by many different things, okay? So for example, if you don't speak the same language as the person who's doing the assessment, you can have maybe a lower score than what would be expected for a person who might speak English or might speak French or might speak another language. Now, the way that they've gotten around that is that actually the MoCA is available in different languages. So in some cases that's helpful, but it's not helpful if the person who's administering the test doesn't speak the same language as you. So there's always sort of a few what we would call biases. Same thing with educational status. So for sure, your formal educational status will impact or might have an impact on your MoCA, but there is an age-corrected score, okay? And always keep in mind that visual and hearing impairment can also impact the result of the score that you get on a MoCA. So it's always good if you ever go to see your doctor for a memory test to actually bring your hearing aids and bring your glasses as well. So I'm putting in a little pitch there. Okay, so what does my doctor do next? Well, your doctor may want to complete some additional testing, such as what we call a formal neuropsychological evaluation, Not always does your doctor want to do that. So it's a very individualized process that's required. But when you do really well on a screening test, such as the MOCA, so sometimes you might get 29 out of 30 on a MOCA, or you might get 30 out of 30 on the Montreal Cognitive Assessment Battery, the doctor wants to sort of stress your brain a little bit more and see how well you perform in situations where your brain might be taxed a little bit more, okay? It's also helpful for some doctors to have what's called a baseline screening tool so that your doctor can follow you over time to see if there's been a significant change in your memory. What does my doctor do next? Okay, so the other thing your doctor might do is assess for some blood tests. Now, these blood tests, again, don't diagnose memory problems, but they might contribute to memory problems or cognitive problems. So the doctor will often check your vitamin B12 level. The doctor will often check your thyroid level. Again, sometimes doctors will check for vitamin D deficiencies. Sometimes doctors might check for what we call electrolyte abnormalities, which are sometimes because of certain medications that you're taking, or because of certain what we call medical comorbidities. Your sodium level in your blood might be low, or your calcium level might be high. And so the doctor likes to check to make sure that all your electrolytes are within normal limits, because that can affect your cognition as well. Your doctor should do a thorough review of your medications. Your doctor will for sure address your sleep habits, which we'll discuss again when I show you the video. Social habits are also, your doctor should address social habits as well, because we know that smoking cessation, and sometimes not complete alcohol cessation, but cutting down a little bit on your alcohol, as well as using over-the-counter medications, can have a direct impact on your cognition as well. And so that's the way the doctor really tries to optimize your cognition. Okay, so I often get a lot of questions about what about a head scan or a spinal tap? And again, there's no diagnostic test that will predict with 100% accuracy that a person has mild cognitive impairment or even Alzheimer's disease. So your doctor might want to do a head scan, or what we call a CT scan, to determine whether you may have had, say, a small stroke in the past that wasn't clinically detected, that may be contributing to your cognitive impairment, okay? Sometimes your doctor might want to do a special scan that we do use sometimes in Quebec, called a PET scan. And a PET scan really looks at, so when you go to have a PET scan, the doctor will, or the nurse will give you an injection of, actually it's just a small injection of glucose. And then what the doctor does, or the radiologist will do, is take a scan of your head. It's very much like a CT scan, but the doctors will look to see where glucose is taken up in your brain. And that sometimes the doctors get a bit of a better picture about what part of your brain is actively using the glucose in an appropriate way, okay? In very rare situations, in a clinical setting, so in a memory clinic, your doctor may also want to do a spinal tap to see if there are risk factors that may increase the chances that your mild cognitive impairment will get worse. But it's quite rare, and often these sorts of tests are used if, say, a person might be a candidate for certain research projects that are going on. So it's really these are really research-based tests, okay? And it's always important to remember that none of these tests are 100% accurate. So many doctors prefer to limit the amount of testing that is performed to try to minimize the amount of worry that might be going through a person's, that might come up on account of having done these tests. Okay, so as I mentioned, age can increase the risk of progression. So when I say progression, I mean progression to develop dementia, okay? But it's not just age, okay? Sometimes if you have had a head scan or a spinal tap that shows some of the pathological characteristics, these people are believed to be at a higher risk of progression. And we know too that people with certain genotypes, or what I would call a genetic footprint, have an accelerated rate of progression, okay? So what about treatment? So someone were to come and see me in the memory clinic and they wanted to know if they had a mild cognitive impairment, and I told them that I suspect that they might have mild cognitive impairment. They asked me, so Dr. Levinoff, what can I do to make this better? And so a lot of times the question comes up, is there any medication that can help this, okay? And I always say at first, treatment is based on prevention of what we call modifiable risk factors. And we really reserve medication for patients with either major neurocognitive disorder or dementia, which by the way are the same diagnosis, okay? To date, there's been no medication that has been proven to be efficacious at preventing people from getting worse, okay? And I write in brackets, I say losing their functional status. And that's because they did do studies where they gave the medications that have been used in the past to treat people with, say, Alzheimer's disease or dementia, these medications to see maybe these people won't progress if they take this medication. And in fact, they weren't able to show that these medications delay the progression. And so these medications are really reserved for people who have a formal diagnosis of major neurocognitive disorder or dementia. Okay, how does MCI differ from normal aging? So again, it's perfectly normal to have changes in your cognition as you age, okay? But patients or people with mild cognitive impairment have a higher frequency or higher propensity to seek medical attention, and they actually have an objectification of their cognitive impairment. So they do say, you know what, my memory's not good, and I want to have it tested, okay? And sometimes, again, doctors can optimize or improve patients' memory or cognition just by making subtle adjustments to medications or treating certain underlying problems that may be contributing to their cognitive concerns. Prevention. So I am a tertiary care physician, but I still believe in prevention to the point where physical activity, I'm a proponent of physical activity. I don't know if you guys are up at 6 in the morning, but I am doing my physical activity. So if my feeling is as a physician, if I can't do it myself, then I'm not really allowed to preach it. So physical activity is extremely important. Diet, I can't say I'm so good at diet maintenance, but I try. So I think diet is really important. I'll get into more specifics about this. Social stimulation is extremely important. And, you know, it's actually quite unfortunate because what we're seeing now in our clinic is that a lot of patients who have had memory problems seem to be progressing, not at a faster rate, but just over the course of the pandemic. And again, we always talk about appropriate management of comorbidities. So physical activity. So there's been this sort of real difficult attempt to try to show in the literature that physical activity can prevent cognitive decline in patients with mild cognitive impairment. And so the studies are very difficult to show because they have a limited time frame. And often the trials are what's called multifactorial. So a multifaceted or multifactorial approach has been shown to be much better than just aerobic activity as well, although there is some benefit for aerobic activity. So when I talk about multifaceted approach, and I believe there's another slide on it coming up, it's usually not just one type of physical activity. So it could be aerobic activity. It could be also stretching and calisthenics. And it also is actually very important to maintain muscle mass as well. And so that multifaceted approach definitely hasn't been shown in the clinical literature to have shown a strong lasting effect on preventing cognitive decline. But because the harms of exercising are minimal, we are strong proponents of non-pharmacological approaches. In terms of diets, so we know that actually, I don't know if I have a slide on that. No, so that's my over-the-counter supplements, but we know that a diet high and rich in antioxidants, so blueberries, selenium, folic acid, and omega-3 fatty acids, as well as appropriate vitamin B12 and vitamin D supplementation has been shown indirectly to prevent progression in patients with mild cognitive impairment. Supplements, again, supplements were difficult to actually find, to actually show. But again, we know for sure that vitamin E has no benefits on cognitive impairment. But again, we know that there are vitamin D receptors in the brain. And so patients with vitamin D deficiencies, or patients, we all know that a lot of Canadian older patients are deficient in vitamin D. We supplement them anyways. They're all water soluble vitamins, as is vitamin B12 as well. So again, when we talk about prevention, we talk about a multimodal approach. So consider adopting all of the above to your regimen to minimize the risk of cognitive decline. And we know that a combination of exercise, healthy diet, and social stimulation can all delay the onset of Alzheimer's disease in people who have MCI. So the multifaceted approach works much better than just specific diet and just specific exercise. Your doctor will also want to help you prevent medical comorbidities. So diabetes, cholesterol, blood pressure, stroke, and heart disease. So again, I sort of use the analogy of, people with diabetes have higher risk of cardiovascular disease or heart disease. And that's that has a direct impact on the cholesterol in your blood vessels. And unfortunately, diabetes doesn't spare your brain vessels. And this puts you at risk for cerebrovascular disease or stroke. So anything that you can do to control your medical comorbidities, and your doctor will discuss that with you, will also have a positive impact on outcome of mild cognitive impairments. So I want to actually take a couple of minutes to give you a little bit of an overview, if that's okay, Megan. That's okay?
Yeah.
To give an overview of some of the things that are going on in our memory clinic now. We've had the unfortunate situation that everyone in the world has, in the sense that the research projects at the memory clinic at the Jewish General Hospital have been put on hold, but they are restarting now. Our research coordinator is Shelley Solomon. Her phone number is actually there if you want to speak with her directly. So Shelley and Chris, I don't know if you guys know Chris Hossein, but Chris, the two of them together have been reintroducing our research program back into the memory clinic. And so on my next slide, sorry, just 1 second here. So Shelley, sorry, I'm going backwards, sorry, I apologize. Shelley and Chris have asked me to discuss the TDCS program. That's more for people with dementia or major neurocognitive disorder. But the CCNA is the Canadian Consortium on Neurodegenerative Diseases and Aging. And we have a lot of ongoing non-clinical trials where we're following a lot of our patients with both mild cognitive impairment and major neurocognitive impairment or dementia at a longitudinal basis. We're partnering now with the Department of Psychiatry as well in terms of offering chair yoga. Again, this is not specific to patients with mild cognitive impairments. So it's always useful as long as there's a caregiver or the person who's doing yoga, who's doing the actual activity, can participate for 60 minutes and use Zoom. That's definitely a great opportunity. Chris wanted me to talk about what's called the Immunocal Study, which again is a nutritional supplement. So Immunocal is an antioxidant supplement, and it's a protein powder. And so participants are asked to add a protein powder to their diet for approximately 6 months, and then followed monthly by the research team with regular MRI scans and blood tests. And the ADME is actually an ongoing study that's published a lot of information, both across Canada and the United States, or North America in general, where there's over 1,000 participants who they're following over time. And they get over 2 years, they'll sort of come into the clinic and have detailed memory testing. FDG is the scan that I spoke about before, called a PET scan, and other different kinds of blood tests. Patients with diagnosis of mild cognitive impairments are invited to participate in these studies in our clinic. I'm actually going to stop there and go back sorry, I'm going to show you now a small video that was put together by my mentor and the founder or the co-director of the memory clinic at the Jewish General Hospital, Dr. Churko, who's since moved to Toronto, but he put together this video. Megan, can you see it?
I can see it, and I just want to, I have some questions for you after the video, and if anyone wants to ask more questions, please write them in the Q&A in the chat, and we'll have those addressed right after the video.
Welcome, Dr. Howard.
Sorry.
It works. It works. Okay. Go ahead.
Good.
Yeah.
Scientist, the Rotman Research Institute and Baycrest Health Sciences, and we're going to be talking about things you can do to prevent dementia, to prevent Alzheimer's disease.
I can't hear it now.
Look at these items one by
Good.
one. Think about what you can add to your life to lower your risk. Tip number 1 on how to help prevent dementia, prevent Alzheimer's disease is look after your medical conditions. See a doctor, get regular checkups, get blood tests, and if you have medical conditions, get them treated, because there's a whole host of medical conditions where the body affects the brain. For instance, sleep apnea. If you snore a lot, maybe you have sleep apnea. People with sleep apnea, if it's untreated, are groggy during the day, their memory is impaired. If you have low thyroid, low B12, kidney disease, all of these and a host of other conditions will have an effect on your brain, affect your memory, and make any dementia or any brain changes worse. So see your doctor, get tested. If you have one of these conditions, get it treated. Tip number 2 on how to prevent dementia, how to prevent Alzheimer's disease is sleep. How much sleep do you get? We know that if people get less than 6 hours of sleep a night, it increases the risk of getting dementia. We think sleep is beneficial for the brain. You clear out toxins in the brain as you sleep. You clear out the amyloid, which accumulates in Alzheimer's. So we are recommending you should get at least 7 hours sleep, if possible 8 hours of sleep a night. Get used to having good sleep hygiene, be in a comfortable room, get the television out of the bedroom, and go to bed and sleep. I've added an extra hour of sleep in my life. How many hours do you sleep? Try and sleep over 7 hours a night. Tip number 3 on what you can do to prevent dementia, prevent Alzheimer's disease is exercise. There's nothing which is more effective in reducing your brain aging, in increasing blood flow to your brain, in decreasing your risk of developing dementia as you get older than being fit and exercising. Everybody should be getting ideally 150 minutes a week of moderate exercise. We know that if you exercise, and it doesn't matter what age you are, if you start exercising, you take up to 5 years off your mental age. There's nothing better for your brain, nothing better for preventing Alzheimer's disease than become someone who gets regular exercise. Decide now, I'm not going to be a couch potato. I'm going to get into an exercise program. I'm going to make this lifestyle change. It's so good for you. Tip number 4 for preventing Alzheimer's disease is look after your teeth. Brush your teeth and floss at least once a day. We didn't used to realize it, but the dental hygiene is very important for your brain, because if you don't brush, if you don't floss, you have low levels of inflammation, and the inflammation in your mouth influences your brain. And this is something which is so easy to look after. It's been shown that people who look after their teeth and floss every day have a lower risk of getting Alzheimer's disease. Tip number 5 for preventing Alzheimer's disease is keep your brain active. Do things which are mentally stimulating, things you enjoy, whether it's playing cards, going to lectures, reading books, but keep yourself mentally active as you age, especially after retirement. We now understand that people who engage in mentally stimulating jobs, mentally stimulating hobbies and activities, this helps reduce the risk of getting Alzheimer's disease. If you can get higher education and go to classes, that's even better. Tip number 6 for preventing Alzheimer's disease and dementia is treat hearing loss. There are about 10 times as many people with reduced hearing among the people over age 65, 10 times as many people as have hearing aids. That means many people have reduced hearing and don't get it treated. We know now that having reduced hearing, for reasons we don't even understand, increases your risk of getting Alzheimer's. And treating hearing loss, getting hearing aids, getting the necessary hearing aids that you need is a way to prevent Alzheimer's disease happening. First, because people with hearing loss, if they don't treat it, they withdraw socially. But second, there's something magic about your hearing. As long as you're hearing the world, it has a very beneficial effect on your brain. So get your hearing evaluated. If people say you're not hearing them, get your hearing tested. If your hearing is low, get hearing aids. Tip number 7 on how to prevent Alzheimer's disease is eat a healthy diet. That means a diet with less red meat, more vegetables, more fruits, a low-fat diet. There's something called the Mediterranean diet or the Mind diet. These are diets where people eat more fish, more chicken, less red meat, more vegetables, and we know that these things in your diet are good for the brain nutrition. In fact, there's a Bake Press brain nutrition guide, and this is online. If you follow the recommendations, we believe it reduces your risk of getting Alzheimer's disease. Now we're on tip number 8 for preventing dementia, preventing Alzheimer's disease. The recommendation is to remain socially active. We now know that people who become isolated, who become lonely, are much more likely to develop dementia as they get older than people who remain socially active. So go out, see your friends, see your family, maintain your social network. It's not only good for you psychologically, it is actually good for your brain. So social activity, become a social outgoing person, get out of the house. This will help prevent Alzheimer's. Tip number 9 for preventing dementia is find meaning in your life. What is the purpose in your life? Many people wake up in the morning and say, there's no purpose in my life. I have nothing to wake up for. You wouldn't think that this would matter in the question of developing a brain disease, but we now know that people who say they have a purpose in life, they have a purpose for getting up every morning, are less likely to develop dementia. Think about your own life and what can give it more purpose. One answer is volunteering. We know that people who go out and volunteer in the community, volunteer to help people they know, volunteer at Baycrest Hospital, they report having a better purpose in their life. And we now know that this protects your brain. Having a purpose in life, volunteering, these help protect you from developing dementia. Tip number 10 on how to prevent dementia, how to prevent Alzheimer's disease is this: lower the stress level in your life. Now that's easy to say, but we all live with stress, especially if we live in a big city. But we now know that stress is bad for the brain. People who have a high level of stress day by day or throughout their life, it affects the brain. It shrinks parts of the brain involved in memory. So what can you do about the stress in your life? Is the stress in your life too high for you? If it is, think about ways to reduce stress. Meditation, relaxation therapy, change in your life to make it less stressful. We believe that while some degree of stress is necessary in everybody's life, too much stress has a negative effect on you, a negative effect on your brain, particularly as you age. So think about what you can do to reduce the stress in your life. It'll help prevent Alzheimer's disease. Tip number 11 on what you can do to prevent dementia and prevent Alzheimer's is protect your heart. What's good for the heart is also good for the brain. So what is bad for the heart? High blood pressure, smoking, high cholesterol, being overweight. If any of these things are a part of your life, think what you can do to help your heart. I've spoken about exercise, but go to your doctor, make sure your blood pressure, if it's high, is treated. If your cholesterol is high, it's treated. Treat to reduce your risk of heart attack. You're also reducing the risk of getting Alzheimer's disease. Tip number 12 on what you can do to help prevent dementia, help prevent Alzheimer's disease, is to look at lifestyle elements that cause diabetes and obesity. We know that these factors, diabetes, obesity, affect the blood flow in your brain. If you can prevent diabetes, reduce your weight, prevent your blood sugar being too high, this is also good for your brain. So look at your weight, look at your lifestyle, look at your diet, look at your activities, and make a commitment that this is going to be the year when you get your weight down. And if you do have diabetes, it's essential you see a doctor regularly and get your blood sugar treated. So treating blood sugar, treating obesity, preventing yourself getting into these pre-diabetic states is also good for your brain, will help prevent Alzheimer's disease. Tip number 13 on how you can prevent dementia, how you can prevent Alzheimer's disease, is to look at your emotional life, particularly depression. As people get older, with the changes in their life, with decreased social contacts, isolation, sometimes the loss of a spouse, people become increasingly depressed. We believe that depression is a risk factor for getting dementia and getting Alzheimer's disease. So if you're feeling depressed, talk to someone about it, talk to your doctor, because depression can be treated. And as the depression lifts, as you're feeling less depressed, we believe this reduces your risk of getting dementia. Depression is a medical illness. You should talk to your doctor, you should get it treated. Tip number 14 on how you can prevent dementia, how you can prevent Alzheimer's disease, is avoid the medications that affect your brain. Most important is avoid sleeping pills, avoid sedatives. Now, sleep is good. People say, I need to sleep. Yes, sleep is important. There are many ways to encourage your sleep, such as a healthy lifestyle, hygiene at night, activities, even a glass of warm milk. But sleeping pills, particularly if you take them every night, accumulate in the brain and will affect your memory. And in fact, there are many other medications that have an effect on the brain. So if you're not sure, speak to your pharmacist, speak to your doctor, avoid medications, particularly sleeping pills, that are affecting your brain, affecting your attention, affecting your memory. Tip number 15 on how to help prevent dementia, prevent Alzheimer's, is alcohol. A little bit of alcohol is probably beneficial for the brain. We estimate maybe half a glass of wine a day, but no more. If you drink 2, 3 more glasses of wine a day, or other spirits, or more alcohol than you should, we know this has a detrimental effect on the brain. We know this increases the rate of getting dementia, increases the chance of memory loss. So have a look at your alcohol intake and reduce it if you're over that level. No more than half a glass a day.
Okay. Can you still hear me, Megan? Sorry.
Yeah, I can hear you and see you.
Okay, so I'm gonna, I think because there's about 10 more minutes,
Yeah.
probably what I'll do is, I see there's some comments in the chat box.
And I have some, I've kind of summarized them, and I have some questions for you. So whenever, if you want to keep it like this, or if you want to put your power, your
no, okay, so let's have a look here.
So can I ask you some specific questions?
Sure.
Dr. Levinoff? Just based on your presentation, I think one of the things that you had mentioned was about MCI, and if there was, they look at the history, and if there was a recent trauma in someone's life, you had mentioned that that could have been a factor that might have precipitated the MCI or some of these impairments, recent impairments. Is there any connection between, you know, a trauma like a death in a spouse that might create some cognitive impairment? I know Dr. Cherkoff just mentioned, you know, depression, but could it kind of kickstart something?
Yeah, so that's a good question. I definitely, yes. There's a big difference between bereavement and grieving versus a depression. Okay. And it's very important to sort of really try to tease out as a clinician, both of them. But I still think that both of them can actually impact a person's cognition. And in fact, sometimes what we see is that a lot of times, again, when you talk about the issue of a functional impairment and mild cognitive impairment, or now maybe we're getting into the continuum of, say, Alzheimer's disease or major neurocognitive disorder. Sometimes what we'll see is a lot of patients who have recently lost spouses within 6 to 12 months, you can see a change in their memory and their functional status, when maybe sometimes the spouse was actually compensating for some of their memory deficits. So it's hard to actually, in certain situations, it's hard to actually say, is it the what happened first? Was it the death of the spouse or the memory problem? And certainly with depression, we know too that depression can be a risk factor, as Dr. Turco mentioned, for memory problems. But people with memory problems also are at high risk for developing depression. So sometimes it's very hard to tease out the two. But definitely what I can say is that a lot of clinicians will try to optimize underlying comorbidities like depression before saying, you know what, we think that this is a bona fide memory problem and not just the depression causing the memory impairments.
Okay, thank you. You also had mentioned people coming into your office and maybe self-reporting some cognitive impairments and things. Does everyone who, I guess, on that gray zone diagnosed with MCI, do they have insight to what's happening to them, or is it presented by maybe a close family member who is seeing some challenges or some differences, and the person might be in denial or not being able to see that insight?
I mean, it's a good question. I think, I think that maybe it's one of the hardest things sometimes with people, and it's hard really to sort of, I think it's hard to be in what I would call a gray zone, to say, I know I have memory problems and I'm trying to optimize, or I'm trying to do as much as I possibly can to keep them from getting worse. As opposed to, say, someone with maybe a more advanced disease who might not actually even recognize. There's actually a term for that. It's called anosognosia. It's, again, a term where a lot of patients with cognitive impairment don't recognize that they have cognitive impairment. And so sometimes it might limit their insight and judgment into the things that they can do. But I would say that a lot of people with mild cognitive impairment still have pretty good insight and ability to recognize, or foresight to sort of see, despite the fact that it's sometimes psychologically a little bit difficult to cope with.
Okay, thank you. There was a question, I'm just looking for, about omega-3. Yeah. 3 fatty acids. I'm just trying to find it. I'm sorry, there's so many.
Yeah, so I think it's omega-3 fatty acids seem to be contraindicated for people on statin drugs. What do you think of that? So two things actually. The pharmacist is better able to guide in terms of what's absolutely and what's relatively contraindicated. So that's the first thing, actually maybe three things. The second thing is that often omega-3 fatty acids, in addition, you can get omega-3 fatty acids in a lot of omega-3 fatty acid rich foods. So one thing I always say is eggs are high in omega-3 fatty acids, and salmon, particularly with the skin underneath. It's not, my kids don't get the omega-3 fatty acids because they don't like the skin, or the fish actually, but it's usually the skin underneath the fish that has the omega-3 fatty acids. So what I would say in that situation is, if it's contraindicated to take it in oral format, then it's probably better to get it in the diet and ensure that it's sort of enriched in the diet.
Okay, thank you. And I know that Dr. Turco was talking a lot about sleep, and sleep is an issue as you get older. We don't sleep as well, and some people take melatonin to help them sleep a little bit. Is that a risk factor for MCI?
So it's a good question. It's actually a very good question. I don't know if I don't know, because actually melatonin is actually a natural hormone that's produced by the body. And as you age, in fact, your levels of melatonin probably decrease to an extent. So in theory, a supplementation wouldn't be a bad idea. Melatonin is often useful if you have difficulties falling asleep, as opposed to maintaining sleep. And a lot of patients I find have a difficult time because they'll sometimes develop a headache the next day from excessive use of melatonin. It for sure, there have been studies in melatonin in terms of sleep and different different situations in the elderly in the hospital, which melatonin has not been shown to be helpful. But I personally feel that if it's, that's the first thing that I recommend to my patients as a sleep aid, because I'm a firm believer that that medications to help you sleep are not good for your brain.
Okay. Thank you. With the clinical trials that you spoke a little bit about, it's a two-parter question. Number one, is your team working with other facilities, such as the MUHC? Do you collaborate in any way for your studies, or is it something that's separate?
So it's a good question. Usually, so I know that the Montreal Neurological Hospital was doing a lot of clinical trials actually with some of the medications that they were using. So it really depends on sort of the facility and the researchers and their research interests. But I know that there's a lot of, there's cross communication. So for example, sometimes the psychiatrists at the Montreal Neurological Hospital, or the neurologists at the Montreal Neurological Hospital will call me and say, you know, your patient contacted our clinic to find out about research studies, and they've given us permission to give to obtain information. So there is a little bit of sort of cross collaboration in that manner. I know for sure the Canadian Consortium of Neurodegenerative Diseases and Aging is a national collaborative effort, which is housed in Montreal, but obviously now, because it was Dr. Churko who started the CCNA consortium, it's moved to Toronto to an extent, not to a full extent. We still have Shelley and Chris and quite a few other researchers who are doing, who are spearheading the CCNA. Some of the studies that are done, for example, if there's a specific scan that needs to be done, can be done at the Montreal Neurological Hospital. And sometimes there is occasional collaboration. So it really depends on sort of the project.
Okay. So I know that people go to their GPs if they're lucky enough to have a GP, and then they would get a referral form to go to the Jewish Memory Clinic. Do they need a referral from their GP to connect with you guys?
Usually, yes. Yeah, and actually, if anybody's familiar with the medical system, a lot of family doctors will only do referrals through what's called the CRDS, which is the, I don't know what it stands for, but it's supposed to be like sort of a centralized booking system. But the memory clinic does not, you do not require a centralized consult through the CRDS. The fax number, I can actually write it.
That would be
in the chat box if you want, but it really needs to be, it needs to be from the family doctor. So it's 514-340-7547 is the fax number.
okay. So they just need a referral fax to them from a GP. Now this could
or another specialist.
Okay, this could also be from like a walk-in doctor if they don't have their own GP. Is that right?
In theory, but it's always, you know, as a specialist, I always find it's useful to be able to have someone to communicate with, especially if there's continuity of care with a family doctor who's known the patient for so many years.
Yeah. I just, from my experiences, that some GPs are very quick in and out, you know, 10, 15 minutes. Or right now, because of COVID, they're doing a lot of telehealth over the phone and things like that. So families are becoming a little bit frustrated in terms of trying to get their needs met. But in due time, if someone wanted to participate in one of your research, your clinical trials, do they still need a referral, or can they call, I guess, Shelley directly?
I think what they would, I think the best thing to do would be to call Shelley, because, you know, I don't want to say classified, but people would need to be classified according to their cognitive profile to be able to be in research studies.
Okay.
So it is, you know, again, it's not beneficial to screen people for memory problems, but if people are interested in participating in research, then they do need to be screened in order to be appropriately, you know, to determine if they're appropriate for the research project in mind, basically.
Okay, I have two quick questions, which I don't even know if you're able to respond to. There's one about in Germany, there's a drug called huperzine, I don't know if I'm pronouncing that properly, to slow down the progression of dementia. Has that been used here?
I've never heard of it. I'd have to look it up. My suspicion, so I'm just looking on my other computer. I suspect that it's probably what's called a cholinesterase inhibitor, an acetylcholinesterase inhibitor, or it might be a form of ginkgo biloba. It's a cholinesterase. It's an acetylcholinesterase inhibitor, which is what we use, the medication that we use to treat patients with dementia. So we would use it for mild cognitive impairment.
Yeah, so it's clear that for MCI, it continues to be the grays.
No, sorry, I'm just looking here. It's a dietary supplement from, it's a herbal medication, sorry. That apparent, sorry, I'm just looking on my other computer, acts as a colon. I've never heard of it, actually.
Okay. So, I mean, thank you, Dr. Levinoff. It seems like MCI continues to be the gray zone, and the best thing to do is, if you have any concerns about any cognitive impairments, to seek out some medical staff to make sure that you get a full testing, as well as to set a baseline. And then you can continually check to see if there's been any change. But, you know, only 10 to 15% of people, as you said, every year, you know, would develop perhaps dementia, but some people do not progress into dementia. It's not a guaranteed. So I think that's something that hopeful, I guess, for people to walk away with.
So I'm gonna stick around. If you don't end the meeting for everybody, Megan, I'm gonna type in some answers to some of the questions in the chat box. If anybody, I can stay for another 5 minutes or so, if that's okay with you, Megan.
Yeah, I'm gonna close it. I'm gonna end the recording. I just want to, and then you can answer anything necessary. Thank you, Dr. Levinoff. I think that just having some insight into this gray zone, and also a reminder of all of the things that we can do to kind of prevent or minimize our risks of getting dementia is helpful. I know I have to go back and check some things off my list and start doing waking up at 6 in the morning like you do. And I just want to say that everyone will be receiving a copy of Dr. Levinoff's PDF, as well as the recording of today, and I think the link of the video that you can rewatch if you'd like. And please fill out the survey. Your comments are really important to us, especially when we are trying to resume services in person. So thank you so much, and have a good day.